Dr. Shishir will be presenting on the membranes of the macula. Since he's occupied in the OPL, so he has shared his video over here.
I'll be presenting Green Valley membranes at the macula, and I would like to thank Dr. Rahul for the including me in this instruction course. So I'll be talking on vitromacular interface disorders. So the presence of an incomplete PVD is the reason for the vitromacular interface disorders. So when you have an incomplete PVD, it may be attached at the disc and the macula, or may be detached from the perifoveal region. And usually this attachment is extremely strong at the fovea, which over a period of time causes anterior posterior traction, and then this finally leads to a macular traction. So vitromacular adhesion. Vitromacular adhesion is of two types, focal as well as broad. So in such cases, you can see on this OCT scan, the posterior hyaloid just touches onto the macular surface. It's a focal vitromacular adhesion, and then if you have a broad-based adhesion, it's a broad adhesion around more than 1,500 microns of the area. If it touches onto the macula, then that's a broad adhesion. So here, patient usually doesn't have any symptoms, and they usually come with good vision or for a routine examination. So here, no intervention is required, and just need to ask the patient to follow up. So what is vitromacular traction? So that is a complication of a partial PVD. So the partial PVD is the cause of why this VMT happens. So here the vitreous is adherent in a broad dumbbell-shaped region encompassing the macular area. As you can see here on this scan, the posterior hyaloid is detached in the perimacular region, but right at the fovea, it is causing a anterior posterior traction leading to a shallow cystoid space as well as a subfoveal detachment. VMT does progress. So once a patient comes with a VMT, the vision will initially be good. So in this case, you can see the 75-year-old male with good vision, 6 by 6. He had VMT at initial presentation, was asked to follow up routinely, did not came after a year with vision drop. He had vision of 6 by 12, and then he had a VMT with the outer lamellar hole which developed over there. So then the question arises, do all OCT diagnosed VMT require treatment? The answer is no. So most cases of VMT syndrome, they have good vision and mild tolerable metamorphopsia and do not require treatment. But however, we need to emphasize to the patients that the follow-up is the most important thing there. So what are the indications for treatment? Vision is a very important biomarker. If you operate the patient with good vision, sometimes there's a risk of vision drop even after surgery. So patient counseling is extremely important. So only if the patient is symptomatic, we need to treat. If there is disturbing metamorphopsia, we can treat. Or if once the vision is reduced. So just because OCT is showing something, and the vision is good and the patient is not having any symptoms, then we don't need to treat such a patient. So now let's come to the epiretinal membrane. So epiretinal membrane is also a consequence of PVD. So I'm talking here about idiopathic epiretinal membranes. So we have the stage 1 epiretinal membrane. Stage 1 ERM will have this hyperreflective membrane onto the retinal surface there, and then foveal depression will be normal. A stage 2 ERM, there will be loss of the foveal depression, and you can see the outer nuclear layer will be appear slightly stretched over there. And most of these patients are still asymptomatic in this stage, and few of them will have these cystoid spaces. And then we have a stage 3 epiretinal membrane. That's when you have the formation of this ectopic inner foveal layer. So it's basically nothing but a hyperreflective band which extends from the inner nuclear layer and inner plexiform layer, and it spans the foveal region. So what this means is the fovea kind of develops an additional layer. It's like a negative prognostic factor. Like if you operate at probably at this stage, then the vision may not improve so significantly after surgery. And then the one more sign which is found in the epiretinal membranes is this cotton ball sign, which is like a round and fuzzy hyperreflective lesion which is seen at the photoreceptor layer or at the interdigitation zone. So this can predict decline in visual acuity over a period of time. And next, finally, we have this stage 4 epiretinal membrane. So here there is absence of foveal pit. There is presence of the ectopic inner foveal layer. And you can see there is like drill-like picture. There is disruption of these inner layers, which you can see here on this OCT there. And they usually, even after you do the surgeries, some of them they don't have good post-operative visual outcomes. Occasionally, ERMs can be secondary to a retinal disease. So in this patient, we can see a tributary vein occlusion, a chronic one, which has led to a epiretinal membrane formation along with some hemorrhage, and the contraction of that fibrotic epiretinal membrane has caused these paralamellar defects you can see in this fundus photograph. Also on the OCT, you can see the disruption of the layers along with the presence of the fibrotic epiretinal membrane. The next is a tractional lamellar hole, which is a separation between the outer plexiform layer and the outer nuclear layer, which creates a schisis-like appearance. So it's a mustache-shaped appearance of at the fovea, what you see there here on the OCT. And as the ellipsoid zone is intact here, usually patients will have good vision. So next is a degenerative lamellar hole, which is like a large cavitation extending into the outer retinal layers as you see. So here the disrupted ellipsoid zone and it can be disrupted and there can be presence of a foveal bump, and it's also called as a top hat appearance. And if you see closely on this OCT, these two membrane-like things just at the edge of the hole, they are called as lamellar hole associated epiretinal proliferation. So I'll just briefly touch upon other membranes which we see in proliferative diabetic retinopathy, which can be from focal membranes to quite extensive, even extending beyond the posterior pole, as you see in some of these cases here. So we can have a tractional macular hole in diabetics where the membrane is pulling one lip of the hole open up like that, along with some presence of subretinal fluid like what you see here. So this is a PDR tractional macular hole. It can present with a tractional retinal detachment as well as a tractional lamellar hole formation, what you see here. And also it can be present with tractional diabetic edema, where you can see cystoid spaces at the fovea there with this dense fibrovascular proliferation. So the decision to treat in cases with proliferative diabetic retinopathy, when you have these membranes, is especially when the vision is significantly reduced, when there is a fovea threatening TRD, or when there is a tractional diabetic macular edema. And just a slide on some honorable mentions. Even membranes can present at the macula in the form of a proliferative vitreoretinopathy in cases with retinal detachment. So here you can see in this case, I'm removing these PVR membranes from the posterior pole. And another honorable mention, sometimes when you leave silicone oil inside the eye for too long, you can have these inflammatory membranes which develop. To conclude, an incomplete PVD is the culprit for most of these vitreoretinal interface disorders, and an OCT is extremely important in picking it up early. So, asymptomatic vitreomacular tractions can be observed. It's important to know the staging of epiretinal membranes as well as to know regarding the biomarkers, as we mentioned in this PPT. And also, visual acuity is an important predictor, and a good decision maker is when to do the surgery. And most of these patients they come for cataract surgery, and an OCT is a good tool to know the status of the vitreomacular interface before planning a cataract surgery. Thank you for your attention.